Good timing. Let's get started. So welcome to our next webinar in Innovations Pathways in Clinical Trials Methodology and Clinical Trials in the Context of Global Health. I've been asked to remind you all that this is February's theme is non-communicable diseases, and if you're in the room in front of you, there is a bit of paper with all the different activities for the month. I'll say what's happening now just shortly, but Grand Rounds is immediately after this at noon, with Sujanta Sankaran is giving the Grand Rounds on non-communicable diseases. Thank you. There you go. So you can stay for that afterwards. But today we have a double header. We have two presenters for us today. We have Geoff Buckle, who is an assistant professor, Division of Hematology, Oncology here at UCSF, who's with us in the room. And we have Kija Luhuti, who is a clinical research physician from Muhimbili University in Dar in Tanzania, who's online. And between the two of them, they're going to share this presentation. And you can see the title there, Advancing Early Detection of Esophageal Cancer in East Africa, Innovation Through Partnership. So we have Geoff and Kija will give their talk. We'll have plenty of time for discussion at the end. But Geoff, I think you're going to start us off. Thank you, Geoff.
Perfect. Yeah, thank you so much. I'll have Kija begin with the first slide that I'll advance. That was already shared. Take us away, Kija.
Thank you, Geoff, and all who are here with us today. As we all know, esophageal cancer incidence varies in different in the world, and the incidence is more common in Asia and eastern corridor of Africa, and also some parts of Southern America is shown in the world map above. Next slide, Geoff. Yeah, and in aspect of East Africa, esophageal cancer, there are two subtypes: esophageal adenocarcinoma, which is less common in our setting, and also we have esophageal carcinoma, which is very common, account for more than 90% of all esophageal cancer cases, and this disease is most common cancer in East Africa, which is among the rest, and is the third leading cause of cancer mortality in our setting. And also there is a high incidence of young adults who are below 45 years of age who are diagnosed with this disease in our setting. And these individuals are normally presented with advanced disease with dysphagia grade 3 or 4 with limited treatment options. And these patients, due to high grade of dysphagia, they normally suffer with malnutrition and dehydration, which this make very poor survival outcome, which is 5-year survival rate is almost less than 10%. So due to this high burden of disease, we have to think the way to fight against it. And I welcome Geoff to proceed with the strategies for controlling this kind of disease.
Thanks, Kija. So we thought it might be helpful first to just provide some background of screening as a cancer control strategy. I know familiar to most people, but helpful to contextualize as we think through optimal ways of cancer control for esophageal. So at the present time, we're currently diagnosing most patients pretty close to death. So most patients have, at a minimum, nodal spread, if not metastatic spread. Most have obstructive symptoms, as we've heard, with a number of downstream consequences, including frailty, malnutrition, and oftentimes dehydration. It's not uncommon for folks to show up and die within several weeks. It's very uncommon to live past a year. To help contextualize or offer a benchmark of what we see within the US, left, the graph that you see demonstrates stage of distribution at presentation, so where we're diagnosing folks. And you'll see even in the US, we see folks that are most commonly diagnosed with regional or distant metastases. And you see an inverse relationship between 5-year survival and stage at diagnosis. So folks that are diagnosed with distant metastatic disease obviously live fairly short life expectancies, but if it's diagnosed earlier, patients live quite a bit longer. At the right, you also see some of the complexities of the treatments that are used: surgery, radiation, immunotherapy, chemoradiation, chemotherapy. These are all fairly complicated, expensive treatments that don't have great outcomes and have a number of toxicities. So obviously a considerable burden from treatment alone without great outcomes. So the goals of screening are obviously to push diagnosis earlier, and the goal is obviously at a time point where there's pre-invasive cancer or cancer precursors before they have metastatic potential, or even early stage cancer with metastatic potential, but before it actually spreads. There are a number of known pre-invasive cancer subtypes related to esophageal squamous cell, which are listed here, which include mild, moderate, and severe squamous dysplasia. These are well characterized through some work that's been done in China. So in terms of treatment of early ESCC and its precursors, we know that overall survival at 5 years approaches greater than 90% for either dysplasia or early ESCC. Some of the treatments that are used in this context are endoscopic therapies, so using a conventional upper endoscopy and then going in with mucosal resection or submucosal dissection with pretty exceptional outcomes. And notably, training to achieve competency in that is actually fairly minimal for most. So the gold standard screening modality for ESCC is upper GI endoscopy with something called glucose iodine staining or chromoendoscopy. This takes advantage of differential iodine uptake amongst cancer precursors in normal tissue, with cancer or its precursors having less uptake of iodine related to glycogen concentrations, therefore showing up as unstained lesions when an esophagus is bathed with blue iodine. As I mentioned before, treatment outcomes can be quite exceptional with early ESCC and dysplasia with long-term survival 80 to 90%. And there was a landmark study that was done in northern China that offered one-time endoscopic screening to folks that were 40, I think it was up to 69 years of age, anywhere in there just one time, and they were able to demonstrate decreased incidence of 20% and decreased mortality of 33%. And this was published in a number of different publications, including JCO. So to introduce effective screening, there are several key steps, which is the ability to identify a target population in China, this was age, or some other high-risk group, a primary screening modality, which we're most comfortable with or knowledgeable about with endoscopy. If you use some other screening technique, for example, a scan or a minimally invasive approach, you still need endoscopic localization going in to actually see the lesion that might be picked up because of some screening technique, then obviously staging infrastructure, and then definitive therapy, which can be anything from endoscopic surgery or more complex therapies like chemo and radiation. When any of those domains are weak, we see failure of these screening programs. I'll shift back to Keisha to talk about some of the challenges we face in East Africa.
Yeah, thank you, Jeff. So in East Africa, we still have barriers on population-based screening for this disease. The main one based on infrastructure, like limited endoscopic capacities, is a study done by Michael Machiro and colleagues indicate that endoscopic capacity in East Africa is less than 10% when you compare with high-income countries. And also we have a very shortage of workforce, especially pathologists in our setting. This limits the engaging of this kind of people in screening modalities. And also the high cost of endoscopy services in pathology in our setting. For instance, in Tanzania, like an endoscopy can cost up to 200 USD for just one session of endoscopy. This is not affordable for many of the patients or people who are living in this kind of environment. And also we have a gap in expertise to perform early treatment surgical procedures, especially the mucosal dissection and mucosal resection in our setting. Also, we have a limited availability of advanced treatment, especially targeted chemotherapies and radiotherapy in our setting. Another barrier in our setting also is physical access of these few hospitals who are very equipped with endoscopies. So in our setting, it's very difficult to replicate what China does for screening just cancer carcinoma. So to overcome what we have as challenges, we have to design strategies which will favor us also to screening these people for this disease. So one of this design strategy need to have several features. One, it has to have low cost, so it can have cost effective in implementing these new strategies. Another thing, it has to have minimal dependence on infrastructure, especially endoscopies and the pathology services. Or it has to be safe and acceptable to the communities for people to be involved and accept the new practice. Also, this intervention has to have high negative predictive values for assurance when people get screening. So as I said earlier, this intervention has to reduce the reliance on endoscopy and decentralized pathology investigation.
Great. So minimally invasive tools for esophageal cell collection have been an area of emerging research that has been under investigation for the past 20 years. These are old technologies, but historically, it largely focused first, I should mention, on adenocarcinoma and Barrett's esophagus based upon the predominance in high income settings. And one of the key challenges that's been faced, which has been documented again over a couple of decades now, has been poor sensitivity. There's either challenges of collecting sufficient cells that are abnormal, dysplasia, or cancer, or there's an element, and this is being demonstrated through some new applications of AI, which is probably challenges around evaluating a sufficient number of cells that are collected, and it varies depending on which of the technologies was used over time. But historically speaking, all of the studies have demonstrated sensitivity that's actually pretty suboptimal and has halted, the advancement of these technologies, though newer aspects of technology could perhaps improve upon them.
Sorry, can I just ask how that's? Oh, it's right here. Never mind. I was going to ask how the cytosponge.
Oh, sure. Yeah, we'll include more on that too. Very similar to the work that we're doing now. So the cytosponge is the one device of these. So we have, one's a sponge that's included in a gelatin capsule. You swallow it on a string, it deglutinizes, the sponge expands, and you pull it out. The cytology brush is something that essentially scrapes off cells from the esophagus. And then there's also a variety of balloon sampling devices, which went out of favor much longer ago, but all had the same issues around this sensitivity. This changed with the emergence of strategies that combine these cellular infection devices with biomarkers. So a strategy that used Cytosponge, which is a UK-based device, was shown to improve the detection of Barrett's esophagus, and actually it was focused on Barrett's esophagus in folks with who are at risk for gastroesophageal adenocarcinoma. And there was a pragmatic randomized control trial that was conducted in the National Health System within the UK that demonstrated that it was improved detection compared to usual care because of the challenges around endoscopy, which is wait times and general less acceptability. People don't love going for endoscopies, and these techniques that have just a pill and a sponge are viewed as much more acceptable by the community. The inclusion of biomarkers improved upon historic limitations. So when cellular evaluation through cytology perhaps failed, either based upon inability to collect cells or evaluate a human evaluating sufficient number of cells, the evaluation of these specific biomarkers actually enhanced this technology quite a bit. And there has been a number of groups that are looking at clinical biomarkers within esophageal squamous cell, the one that we're focused on in Tanzania, as well as squamous dysplasia, suggesting that there's potential biomarkers in the space as well. Building upon the work that's been done, largely focused on Barrett's and esophageal adenocarcinoma, there has been an emergence of early detection, or I really should say screening research in Eastern Africa. So Mike Machero, a colleague, a collaborator out of Tenwick Hospital in Bomet, Kenya, Western Kenya, did the first screening study that tried to demonstrate the prevalence of dysplasia within the community-based population, and then also looked at first-degree relatives of those that were diagnosed in a region that has done a number of different studies on the etiology, and they found that the rate of dysplasia was prevalence of dysplasia was around 14.4%, though interestingly the high-grade dysplasia rate was fairly small at around 3%. Then there was an effort led by colleagues at IARC and Moshi to look at minimally invasive sponge sampling using the cytosponge amongst the community-based population. And amongst slightly more than 100 folks, they demonstrated that it was safe, acceptable, and feasible amongst those that had no symptoms. And then Clement Nar, there's a spelling error, it's N-A-R-H, who is a postdoc, or was a postdoc at IARC, originally from Ghana, leveraged a bunch of harmonized case control studies that have been conducted to try to understand the etiology of ESCC in this region, which historically has been largely unstudied. And they pooled those case control studies to try to develop a risk questionnaire to help identify questions, 6 questions set essentially that would identify a patient who might be at high risk for ESCC, which is a critically helpful tool with conceptualizing some of the work that we're now doing. So all of these studies have kind of set the stage for advancing screening and early detection work in this setting. I'll shift it back to Kish to give us an update on this work that we're doing.
Thank you, Jeff. So the study which we've been doing for over the years now is called the Investigation of a Novel Strategy for the Detection of Esophageal Cancer Carcinoma. This study is housed under the collaboration of MOAS, RSI, and UCSF, but it's a collaboration of almost 4 institutions who are involved in this study. We have UCSF, Johns Hopkins University, MNH, and MOAS, and the capsulomic labs. So next slide. So this study is mainly done in Dar es Salaam at Muhimbili National Hospital. The hospital is the largest public hospital in the country, which is used as a teaching and the main referral hospital center with the capacity of over 1,000 beds, and also average ETC over 44,000 patients in daily basis as outpatients. Next slide. Yeah, so this study only employ a diagnostic strategy which combines esophageal sponge sampling using an EsophaCap device with a novel molecular biomarker assay for early detection of ESCC, as well as esophageal squamous dysplasia. So as Jeff explained, EsophaCap is almost similar with cytosponge, but it's a little bit smaller with a diameter of 20 millimeter when it will expand. So it is which is encapsulated and also hold with the cyrus and the handle. So Dr. Mirza and his team developed methylation biomarkers in 3 different genes, which when they conducted a pilot study on this data indicates the sensitivity of detecting esophageal cancer carcinoma to be over 80%, as well as the specificity of over 90%. So our study was launched in March 2022, and it is ongoing up to date. So the main objective of this was to evaluate sensitivity and the specificity of the combined esophageal sponge methylation biomarker strategy among esophageal cancer carcinoma cases and control. And also a secondary objective was to evaluate sensitivity, specificity of the combined esophageal sponge methylation biomarker strategy among patients with histology confirmed ESD and control. Also, we want to evaluate safety, feasibility, and accessibility of sponge sampling with a sample urban setting in Tanzania. So the study design is a 2-arm study. The first arm is normal, we enroll esophageal cancer confirmed cases, and these patients they undergo EGD. When the tumor or mass observed, we took biopsy, and then we follow the result. If as confirmed to have the disease, we undergo for a case arm. And this arm, we aim to enroll 63 patients. And also the second arm is a control arm. So in this arm, we enroll all patients who are scheduled for EGD at the hospital, but they not have any symptom related to malignancy like dysphagia or odynophagia. So this patient will undergo EGD as usual. If no mass or disease, they will undergo robust endoscopy just to identify if there's any region which has which are there in the esophageal mucosa. If it is unstained, so it means the patient has no disease, will fall under the control arm. If the patient has any region in the esophageal mucosa, we'll take the biopsy and follow the result. Either the patient has ESD or has the disease or doesn't have the disease. So that is how currently we are enrolling patients. Next slide, Jeff. Yeah, so all patients who are non-esophageal cancer cases will have to undergo robust endoscopy to confirm their disease status, either with biopsy or without biopsy. And also all these patients will swallow the EsophaCap sponge device. And after swallowing the device, it will stay in the stomach for about 5 minutes. Then we have to take it out or pulling it out. So when we pull out the device, because the sponge exploded, it will scrap esophageal cells from the esophageal mucosa. And then these cells will go in the lab to undergo etiology and methylation biomarker analysis, but also during the procedure, post-procedure, we also assess for feasibility, where we capture how many attempts was done for patient to swallow the device, and also we assess acceptability, where we tell the patient to score between 0 to 10. So what is the experience with the procedure of swallowing the esophageal device, and also we assess safety evaluation immediately after the procedure, and also after 7 to 10 days post procedures to see any side effects of the intervention. So the progress of the study we had two phases. Phase one involved safety lead or checklist. So the phase one, we enrolled almost 40 patients for over 6 months, where 8 patients were able to swallow the sponge, and we collect sample. So we had a swallow rate of almost 57% for over 6 months. So we saw the recruitment is a bit slower, so we had some we have to do some amendment, but after reviewing the data and the DSMB meeting, we found that there's no any major adverse events. There were minimal adverse events, so we continued the study. After amendment, we were able to enroll patients who are suspected to have the disease and those who also have the disease. So in phase two, we were able to recruit over 100 suspected cases, and among these patients, 87 were confirmed to have the disease, who were categorized as a case arm, and among those patients who were enrolled as suspected, for almost we had a swallow rate of 41%. So up to date, the total number of the collected specimen is 51 out of 63, which is 80.9% of the total AfrECC goal. So up to date, we didn't encounter any adverse or severe adverse events during the case arm. So about the control arm, as I explained, we enrolled patients who are scheduled for endoscopy procedures at MNH but have no any malignancy-related condition. So these patients undergo endoscopy and also undergo endoscopy. If there's no any lesion or the unstained lesion, they go directly to the procedure of swallowing the esophagus, and also we proceed with other study procedures. But if we have a stained lesion, unstained lesion, it means we have to do biopsy and also observe if we have any ESCD and the disease. But unluckily, we have very few patients who had unstained lesion, but after following the biopsy, that all of them has esophagitis with no any esophageal dysplasia or esophageal carcinoma. So next slide, Jeff. So, but to launch the control arm, we had a delay for over 12 months. This is due to the process of procuring a new endoscope to support the study implementation. Also, we had to conduct several training for our endoscopists to be able to perform the logos from endoscope procedures. So in April 2023, we were able to send our 2 endoscopists at Tenwek, Kenya in Bomet, so as they learn logos from endoscopy, and also we repeat the training to have the assurance of their competencies on July the same year at Muhimbili National Hospital. So we had 2 endoscopists who were very covenant with the logos from endoscopy procedure, who were able to support the study. Also, we conduct a training with NCIPI, who led the collaboration of China screening study to equip our pathologists to be able to review and understand how to classify dysplasia, which will be very important in our intervention. So the control arm was launched around August 2023, And up to date, we were able to enroll 85 patients, and 74 were able to swallow the sponge and correct the specimen. So the swallow rate among control group is 87%. Yeah, so far on the safety of the sponge sampling in all arm comparing control and cases of only mild adverse event which we normally observe, and the reading is nausea, which is 2%, followed by throat pain, cough, and the rest is vomiting, which is 2%. We never encounter any adverse event in 7 days follow-up, and we never had a severe adverse event, as I stated before. Yes, so our collaborator at Johns Hopkins, they conducted preliminary analysis for 51 cases in 26 control, and they show a promising result where a modified biomarker model demonstrates area under the curve of 0.97, which indicates high sensitivity and the specificity of detecting esophageal carcinoma. So these are some of the pictures where we are preparing Logos iodine, which is a very important ingredient to perform Logos comendoscopy. And also the next slide show how Logos comendoscopy appears. If the esophagus is diseased, it will not take the Logos iodine color due to lack of glycogen in the cells, and you see some pictures there, unstained lesion. So any place where there's unstained lesion, we have to biopsy and to confirm if that is esophagitis or ESD or esophageal carcinoma. Yeah, so during the implementation of this study, we have several operational challenges. One, as I said earlier, is a narrow window to recruit patients with esophageal carcinoma, because this patient has to travel far away to the restaurant for care, and also most of the patients come at the disease dysphagia grade 3 and 4, which is limiting to them to swallow the sponge. So to mitigate this, we had to do amendments so as we'll be able to enroll the patients when they come, so we can enroll the patients who are suspect based on the symptoms and radiological investigation, and then we follow up the results. If they have the disease, we'll put them in the control arm. So another operation challenge which we also see and we were able to implement in the capacity. Also, we had to improve capacity for research team in administration of esophageal cap sponge device. As I said earlier, we had to train endoscopists, nurses, and lab technician on performing logo chromendoscopy, logging sample, as well as how to classify this plastic lesion for these samples. So another thing, we have limited expertise at our collaborator, so we normally rely on the lesson from China. Also, we had issues on quality assurance with digital pathology and the whole slide scanner. So these are some capacity building which we focus on so as we can implement the study at a broader range. Yes,
great. So,
welcome.
Thanks, Keisha. So, we are building off of a study now that has demonstrated safety, acceptability, and what we find to be promising diagnostic accuracy. Obviously, there's more samples that need to be analyzed. There's probably going to be some attenuation of that data, yet it still is compelling as a potential tool. However, as we think through next steps and how to bring this technology to impact for this disease that is highly fatal and an immense burden in this region, we recognize that hospital-based diagnostic studies are insufficient for scale. Yet, conventional next steps and screening studies, which are large-scale population-based trials, aren't really feasible, largely linked to the lack of endoscopy and pathology infrastructure. population-based registries are very helpful for demonstrating impact. Limited long-term follow-up systems or mechanisms, they'll all highlight that we've had immense success with 7-day follow-up and also outcome studies that we've been doing for treatments in this region. And then there's major financial and commercial constraints. With time constraints, I've kind of removed some of this, but we've run into a number of issues with manufacturing devices that are viewed as competition within the United States. So they've essentially ceased production of the EsophaCat. We had to switch to another device that has the exact same metrics and designed exactly similarly, which is called the CCD device. But it's very interesting to see like the downstream effects of globalization, where competition here can actually impede innovation in resource-constrained settings where there's less financial incentives for innovation from a commercial perspective. That being said, we've developed what we view as a pragmatic intermediate step that could help advance this technology and demonstrate impact. And Keisha will tell you a little bit about the project that he's leading.
Yeah, thank you. So, as the team and I also developed a research, so we were able to scale up this intervention to the community. As we saw, the preliminary finding are promising for detecting esophageal carcinoma at the early stage. So, the current project titled the community-based pilot study for esophageal carcinoma in Tanzania. This study is normally, this study is also funded under the Big Cat grant, which we're currently operating. So the overall project of this study is to evaluate the feasibility of a risk stratified screening model outside the hospital or tertiary care. So the first aim of this study is to develop a culturally tailored community engagement strategies for piloting esophageal carcinoma screening study in Tanzania, using a minimally invasive sponge sampling coupled with analysis of novel biomarker. And the second objective, we have to identify barrier, facilitators, and local preferences among implementing a pilot screening studies in Tanzania. And the third aim is to pilot the designed intervention in the high-risk communities in Tanzania. So we are aiming on engaging 4 communities, and we are planning to enroll for about 200 patients in this pilot program. So the study approach, the study setting, you will be in a community which is semi-urban in Dar es Salaam, and the operation we target to recruit all patients who are 18 years age and above, with a risk of having ESCC. And the risk here will mainly use the esophageal cancer risk questionnaire, which was developed by our colleague AICCR, who has conducted a study, case control studies from in East Africa, as Geoff explained. And also that design is explorational sequential mixed method design. This study will be actually in 2 phases. Phase 1 will involve engaging the communities in the quantitative study. And this phase 1 will normally we think on establishing this community advisory council, which will help us to get trust to the communities, to have a direction feedback between the research team and the community, and also to get their views in design and implementing the study. And also under their guidance, we will also conduct community mapping to identify community sites which have a minimal infrastructure to support esophageal sampling procedures. And also we identify potential sites which will be piloting the intervention. After having those information and also guidance of CAC, we will also do a qualitative research. The aim of this research is to capture barrier, facilitators, and the community preferences for esophageal carcinoma screening strategies in the community. And we will mainly use safer framework in identifying these barriers and facilitators for the screening intervention. After having those information from the qualitative studies and the community council, we will integrate with the data, and also we'll use those information to design the pilot study to be implemented in the community. So this will be a phase 2 study. So a phase 2 study, as I initially said, we will we will normally implement in the community, and we are aiming to target 10 sites within the community in Dar es Salaam, and we will use the East Africa Space Consortium carcinoma risk questionnaire to identify risk group for sponge sampling. And this questionnaire has like seven questions, which normally have esophageal cancer risk factors like alcohol use, cigarette smoking, biofuel use, as well as dental decay and oral issues. So all high-risk individuals who score high in the questionnaire will be subject to a sponge sampling. We're using cell collective device similar to a esophageal device, and also the data who will be collected from the sample who are being collected will go for biomarker analysis with our colleague at JHU University. And after having the positive results from this kind of patients, they will undergo endoscopy to confirm the disease status. This will be the modality of this screening intervention. And any individual who is negative on the biomarker analysis will stop there. There will be no further testing for this kind of individual. So we're hoping that preliminary data from these studies will inform a larger scale certified sequential space-specific carcinoma screening in low setting resources. So we are hoping that if this intervention will be successful, it will be like a model for screening cancer in low settings like East Africa.
Great. So just a few last closing thoughts. Thanks, Keisha, for running through all of that. So esophageal squamous cell carcinoma is a leading cause of cancer morbidity and mortality. There's countries where it's the leading cause of cancer death amongst men. It's highly fatal amongst almost all. Population-based screening probably offers one of the few viable strategies to have impact, particularly when benchmarking against our successes here or challenges in treating this disease. Implementing screening in low resource settings faces immense challenges that are highlighted here. We've summarized some, there are certainly others, but the challenges that we face are not only the clinical infrastructure, but also implementing research and developing trials that are viable given resource constraints or competition with clinical care. Our hope is that developing innovative resource-adapted strategies that are efficient and aligned with the existing infrastructure are essential, though at times that may require some compromise in terms of what's the ideal study to advance the science. Thanks a lot for the opportunity to present this work, and I'm happy to answer any questions.
Thank you, Keisha and Jeff. Thank you for your presentation, laying out the challenges, considerable challenges, and some interesting parallels with screening strategies across non-communicable and communicable diseases. Maybe we'll have time to talk about that. But any questions on Zoom or in the room? We have some time for questions.
Thanks. Yeah. Sorry, very cool. Is this part intended to happen in health facilities or like actually like at people's homes?
It's a great question. Keisha, do you want to take a stab at answering that? I'm not sure if you heard the question. Thoughts around introducing this phase 2 within people's homes or health facilities? How are you envisioning how that plays out? I'm happy to share my thoughts too.
Sorry, Jeff, can you come again?
Location for phase 2 of your community-based pilot study. Are you thinking within homes? I realize my computer doesn't have a microphone. Are you thinking in people's homes or in like community based health facilities like district primary care centers?
Thank you. Actually, we are currently conceptualized on involving lower health facilities, especially health centers in your setting. These are normally located close to the communities.
There's been some kind of consensus, and there's not enough people working on this to kind of develop a clear standard around this, but there's a general perception that with these devices, which have a theoretical possibility of actually detaching, which we have not seen, but 1 in 300, reported in the literature, it should be within about a 30-minute drive of an endoscopy site. So as we think about scale, there's been very deliberate attempts to kind of identify communities in Dar es Salaam that would have access to an endoscopy if there were an event that is, low frequency, but potentially catastrophic if somebody has risk factors. So that's kind of one element, but whether it's at a home or, you know, in a market or primary, you know, we're hoping to lean on the community advisory council to kind of guide us on what they view to be appropriate and what's an easier place to recruit folks with some parameters around safety.
Sorry, two other questions. Is it being used to diagnose other things like gastric cancer or like, I don't know, eosinophilic esophagitis or like infections?
Yeah, we haven't included those aspects in our study. I mean, interestingly, anyone who detects positive has an endoscopy that could theoretically pick up. I know that the groups in China there's an interesting mortality reduction that comes from discoveries of gastric cancer in that context as well. Gastric cancer in Tanzania is not nearly as prevalent. So theoretically, you could catch it on endoscopy, and you potentially could catch somebody who has a gastric cancer using these sponges that are collecting, you know, abnormal, depending on the biomarkers. Like if we're choosing biomarkers that are, you know, specific to ESCC, maybe not, but cytology could certainly. We didn't describe this, but we are looking to see the comparison between cytology versus biomarkers to just demonstrate from a, you know, efficiency perspective, like there actually is, even if it's more expensive, it's more valuable to have the biomarkers, but there's nothing else that we're including in terms of health outcomes that we're looking at diagnostic perspective.
And like this case control design, like can it potentially overestimate the sensitivity just because like you're starting with cases that are like already detectable? And I don't know, maybe there's something about the controls.
We're looking at
there's some bias. I mean, I think it's great. I was just thinking, like, what are potential limitations of this design?
Yeah, I mean, theoretically, we're not trying to capture, because we're recruiting known ESCC cases, and something that we kind of glossed over, like the goal is just to capture ESCC cases. The challenge when we waited for folks to get a diagnosis, people have an endoscopy for diagnosis, they're sent home, they're told to come back in 2 weeks. Those patients weren't coming back. Okay. So when we capture,
just trying to make it easier to diagnose.
Exactly. So if we say, and there's a pretest probability about 90% of somebody has dysphagia, they have ESCC. So we're recruiting the folks that are coming and saying their dysplasia, consenting them, having them do the sponge sampling prior to endoscopy. That's for two reasons. One, to make sure they're not lost to follow-up. And then the second reason is if you biopsy somebody and there's blood present, it could impact the performance of the assay. But if somebody essentially has a sampling procedure and they don't have ESCC, we're dismissed. They're not part of the study. So we're not really trying to estimate like incidence of ESCC from it. It's really more of discrimination of how does the assay perform in somebody with ESCC versus somebody that does not. And then the control hopefully gives us some prevalence estimates of what dysplasia. There's only one study that's looked at it, and specifically in a very, very different population in Western Kenya. However, our limitation, the critique that we'll get if we were to say that we're making estimates around community prevalence, is that we're recruiting people who have an indication for an endoscopy as it is. So it's definitely a distinct patient population. How that influences is probably not entirely appreciated, but it's not, you know, general population. And we're doing that very specifically because we don't have to pay for the endoscopy, which is $120 plus the cost of pathology. So it makes the study a whole lot more expensive. Yeah. We're just sampling everyone with endoscopy and sponge.
Great presentation, Jeff, Keisha, thank you. The biomarkers, I don't know if I caught what they were. Are they tissue-based biomarkers?
Methylation markers, like selected genes that were actually chosen from TCGA, and then looked at differential expression based upon patients that have ESCC and not. And then from those, there's an optimization process that we're not really part of. It's our collaborators at Hopkins. So I may not be able to provide a ton.
No, it's okay. But the matrix is the tissue. The tissue.
Correct. Yeah.
Whatever.
Exactly.
So what I was thinking as you were presenting, and the fact that you shifted to community-based, is what consideration you had given to volatile organic compounds, VOCs, as a combination approach to the sponge
for diagnosis as well,
for screening. So there are several. The reason I know about it is because we're looking at it in tuberculosis. There's a couple of companies. One's called Alstone in Cambridge, and one's called Enos. I'm looking at volatile organic compound measures in breath, and the devices are in prototype field implementable. But they're pretty cool. Some early data suggests for esophageal cancer in the high 80 percentile to 90s even Obviously, dependent on the populations they screen, because some of these studies aren't as rigorous as you'd want them to be, and they overestimate. But a study design where you would take exactly what you have, a community-based approach, pilot, and attain VOCs before the sponge, VOC after the sponge, and then they get the routine other parts of the study, could be a really nice, non-invasive addition to the project.
Yeah, that's super fascinating and definitely outside the scope of what I've been exposed to. So I know there's a lot of folks that are
emerging technologies.
Yeah, I mean, I think it's been a fascinating, this journey is now, we're 4 years into it, and since then, AI, like there's a paper that came out of China that demonstrated just AI evaluation of historic cytology improved like the gaps. And so there's an outstanding question of, is it going to be methylation markers in tissue? Is it going to be AI microscopy eating these? Like we don't really know, but we have what we have. It's promising. It takes a long time to develop this. There's a lot of barriers that have kind of led to these major delays. There's definitely parallel interest in trying to use these types of technologies to understand the etiology component and what either collecting samples with microbiome or a variety of other exposures, and the ideal study would embed all of this. It's a topic that's pretty hard to get funded, which is what we're running into. It's not a priority in NIH or elsewhere.
Well, Gates is funding these tools, so you might look into it, do some reading. I think Gates gave Alstone several $1 million. They just ran a 1,500 patient trial in the UK screening for esophageal cancer with the Alstone device, which is about this big. You breathe into it for 30 seconds. So, I mean, it could be a nice way to take emerging technologies that's being applied in the UK and look at it in a low middle income country setting and maybe ask Gates for some money.
Yeah, that I can do.
Think about it.
No problem asking. I appreciate sharing that. That's super interesting.
Yeah, I can somehow get you the links to Alstone, or you could just look it up yourself.
Yeah, no, I definitely will explore. It's fascinating.
If there are any questions online, raise a hand. Or are there any questions online? I was just going to push you a bit more on the sort of screening for multiple diseases. Are there other sort of routine screening programs in these communities? Maybe this is a question for Keisha, where you could sort of piggyback, where maybe some sort of gastric sample would be useful. I don't know, diarrheal diseases, is that useful, or viruses? I mean, this is outside of my expertise, because it seems like, this is quite invasive. And I noticed that you really had about 40 to 50% swallowing rate. So quite a lot of people struggle to swallow them. I wonder if there's any way in sort of partnering with other screening approaches. Is there something you looked into?
Yeah, I'll let Keisha answer the question around screening, but just to clarify, the swallow rates, we're seeing low swallow rates amongst folks that have dysphagia, which is our case population, which theoretically would never get. If somebody has dysphagia, they should get an endoscopy, and that's like standard care. But because we're both doing endoscopy and trying to demonstrate, amongst the comparison group, they're not, and it's not surprising that they're actually failing given how obstructive lesions are. But if you look at the control population, which represent the community base, it's close to 90%.
And I guess this study here will give more data on sort of more of a typical community
although my argument would be it's kind of already proven that it's acceptable. There's applications of the cytosponge now. You can take a general population. For example, England, they have 120 patients at a Moshi. We have now 78. About 1 in 10, which is exactly what I would expect. I have about 1 in 10 patients under my care that have no upper esophageal lesions and they can't swallow pills, which is, I think an acceptable failure rate. So we would expect that if you were to target a general population, the feasibility is proven. But maybe the challenges of accessing people and embedding it into the health system, given the infrastructure requirements, is an excellent question. And maybe Keisha could talk about, I don't know if you can hear me, Keisha, but talk about other cancer screening or other screening approaches that could be linked to this when we think about introducing it into the community.
Yeah, Jeff, if I get your question, you are asking about other cancer screening apart from esophageal cancer who have done in the communities, so we can replicate. Is that right?
Yes.
Actually, in your setting, the screening which were more successful for cancer screening is for screening for, I think, for esophageal, is screening for cervical cancer only. I can say, and and now they are trying to do for prostate, but the one which is community based is more esophageal cancer. They're doing outreaches, and these are very successful because they are funded by the Ministry of Health. But most of them, they are not going direct to the community. They go to the health centers, which are close to the community, so community can, they announce, the community can gather to the health facility which is nearby and then undergo screening. And they're not available all over the years, they're just periodically. But at the Ocean Road Cancer Institute, they also establishes a cervical cancer screening clinic. Which is running all over the years. So people who need the screening, they go there for screening for cervical cancer, and they normally advertise on the media and other source of social gathering. So for us, we'll learn a bit from it, but I think it will depend much on the information which we'll be getting from the community advisory committees and the IDI, which will be conducted to the community, so we'll get more insight on how to approach the community screening in our case.
Thanks, Keisha. I'll add one more comment, which is something that you've brought up to me and we've talked a bunch about, but the geographic heterogeneity of incidence that's seen globally in East Africa is also seen locally too. So there's definitely areas within Tanzania where there's perceptions, and it's hard to prove this without population-based registries, but where most patients are coming from. And so there's one kind of challenge of how do you operationalize screening across a national health system, and that seems very hard to do. There's a lot of competing priorities from a opportunity cost or whatever metric you might want to suggest. It probably is hard to justify because it's still a fairly low incidence relative to other problems. But if you look at the number of patients that are coming, for example, Tonga, which is in the northern part of the country, you could see a model where we actually focus on places that either have known high risk, known risk factors that are in high prevalence, or seeing an unusual high number of cases or a high number of young cases as we wait for the maturity of population registries. So you could do mass campaign screenings, for example, if they are more targeted. That could be a way of having impact, and something that we've thought about, but because of feasibility is why we're focusing on DART to start.
And just maybe this is a simpler question. So just to explain, there's the pill is swallowed, the sample is taken. What are the processing steps between sort of getting results? Like how easy, can you store the sample before it goes to the lab? Like how quickly does it need to travel? How long does that process take? How much work is needed?
Yeah, right now we're doing all the analyses at Hopkins, so it doesn't matter. It's shelf-stable, it can sit for a while. You have to get it through customs to make sure it doesn't spill, those challenges. But they do have separate funding to develop a chip that would allow for in-country, and they've been, I guess, working on it for 7 to 8 years. I haven't seen data around it, but a call a couple of days ago indicated that they're seeing progress, and they said that it was very exciting. As expected, it's taken 8 years. Like they should have it by now, but it's engineers out of the Bioengineering Institute there. Awesome. So there's an opportunity there to bring this all testing, and then it would be a matter of running the samples and perhaps getting our turnaround time much quicker.
Right. So that's your vision, is that it would be you take it out, you put it into a little box, put it into the machine, and then it gives you a readout in a few hours. Okay. So it could be something that could be very, very point of care.
Yeah, it's a really good question, and probably it's a critical consideration as we think about reflexive testing in a community base. We need to process the samples fairly quickly, particularly if there's a risk for loss of follow-up.
Cool. Yeah, the other, if I may, one more question. So the other like innovation in TV screening is cough screening, and about how. So one of the new things they're doing is either you cough into your phone and it like detects the cough, or it's passive cough detection, and then they have these models now which can disaggregate sort of just a cough from a TB cough, from different types of cough. I don't know. Is that something is that related to esophageal cancer? Is there any like signals there? Is that something that is reasonable, or I don't know?
I think potential. There's a lot that I don't know about how what is it exactly detecting, and I would imagine that the maturity of research around differentiating for this disease, which has been under researched by others, we may not know. But I would presume if they're able to do it for they'd be able to do it for cancer or the microbiome that follows it, which is probably somewhat distinct. That data, from what I understand, is somewhat flawed of what we know right now.
Right. So lots of gaps, lots of
It's
work.
great to it's really interesting, the things that you don't hear talking to other folks on cancer research, talking to IT. Maybe we should learn more.
Yeah, well, I mean, that's exactly the purpose of these
This is
sessions.
why we're having these sessions, is to generate collaborations and knowledge sharing. Both the COF and the VOC concepts are clearly emerging. They're funded through NIAID, UCSF and Heidelberg University scout internationally for advancing biomarkers that are prototype ready. And some of them that we find have applicability to COVID, some are HIV, but there's some that are related to cancer. And VOC is one that's really risen to the top, so you might be interested.
Yeah, I'll definitely look.
And last question, who are your colleagues at Hopkins?
Steve Meltzer is the main point of contact, and his team.
Andreas from Hopkins.
I think we can finish there. Thank you, Keisha. Thank you, Jeff. Thank you so much. That was fantastic. Thank you.
Thank you.